afternoon, and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy, all the way from Bamako, Mali this week. How are you doing, Dr. Murphy?
Doing quite well, nice and warm here.
Very nice. Dr. Robert Murphy is the Executive Director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, and public health questions each week on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be addressing the latest U.S. COVID statistics, headlines, and answering questions through today, March 7th. We invite you to submit your questions down below via Facebook at NU Institute for Global Health or by email at globalhealthinstitute@northwestern.edu. Starting with the updated COVID statistics for the US. Average new hospitalizations per day, 2,757. In the same week in 2023, we saw 3,641. Average COVID deaths per day, 135. In 2023, the same week, 300. New vaccine uptake, the 2023 vaccine. Adults, 22.2%. Those 65 plus, 41.5%. And children, 13.1%. Dr. Murphy, your reactions to those numbers?
Well, the encouraging one is the death rate. It's a very easy marker to follow. I mean, because that's a reportable event. And that's sliding downward. As we mentioned, March is when these respiratory viral infections kind of start going down. And so we're entering the end of the season. So it's good news. As far as the vaccine uptake, I mean, that's just not going to happen. Still not too late to get these vaccines, even the flu vaccine, because there's still a lot of disease around. So, people should take advantage of that.
Yes, and speaking of there being a lot of disease around, we had a submitted question this week from a viewer who got the quadrivalent flu vaccine in the fall, but is seeing a lot of influenza B in their area. Does the quadrivalent B vaccine cover influenza B?
Yes, it does. Yeah, so the quadrivalent flu vaccine covers two influenza A's, H1N1 and H3N2. And two of the Bs, so it should cover it for them. So it's a good vaccine for places where there's a lot of B.
And regarding the new COVID vaccine recommendations that we spoke about last week, this being for older or immunocompromised adults getting an additional vaccine booster in the spring. If you have had COVID before and have been completely boosted, how long should you wait to get this new vaccine after you've had COVID?
Yeah, after you've had COVID, your immune system has had a very significant challenge to the virus, and so you don't need it right away. And I would say and what the CDC is saying is the minimum time is 90 days, 3 months. You should wait before you get another vaccine. You just wouldn't need it before that time period. We know that the immunity starts to go down, so 3 months would be the minimum, and that's just the minimum. It could be a little bit longer. It's really up to you and your physician when you want to take it. Obviously, the people at the highest risk, people with underlying medical conditions, the elderly, should consider doing it sooner rather than later.
Mm-hmm. And about that updated vaccine, there was new data released from the CDC this week regarding the efficacy of that vaccine against moderate and severe COVID. Could you tell us about those data?
Yeah, the data are quite interesting, but not surprising, that if you got that new vaccine, the one that came out in 2023, at the end of 2022, actually, there was a 50% benefit for progression to severe disease. This is a very large study, 128,825 people total in the study. 17,200 of them received the vaccine. So they have a lot of data, and mostly what I could tell from that report was that it decreased emergency department visits. So that's a good sign for severity of disease. It depends on the culture. You know, some places people go to the emergency room more frequently, some not. But in this particular study, it was quite clear that the visits to the emergency department were much less in people that took the vaccine. So that's just good clinical news, just verifying that the vaccine still works.
Absolutely. And while we're here, can you quickly explain the difference between why we call some a vaccine and some a booster? And is there any news of updated vaccines coming?
Right. It's very confusing because even in this report, they were calling it a booster. It's actually a new vaccine. Like the flu shots when they come out, they're new. They're not really a booster. And so the last vaccine, you know, that was mostly what people got in 2023, that was a brand new vaccine designed really for Omicron. So that it sometimes gets referred to as a booster. Booster would be like the same vaccine given again. So this, if you're recommended now, like we just talked about, to get another vaccine dosage, that would be a booster because you had already had the same one before. So the same thing could be a new vaccine or a booster. It's just the semantics are confusing here. But what's going to happen, the head of the CDC, Mandy Cohen, Dr. Mandy Cohen, has sort of announced is that they're going to be tweaking the vaccine again. So there'll be another new vaccine that comes out in the fall sometime, just before the next respiratory infection season. So that's going to be a new vaccine. So that's coming this fall. But if you're at high risk in particular, take the current booster. You know, now you can call it a booster if you had the first one, and just take it because it does offer that protection as I talked about.
Mhm. And does changing this formulation, they're targeting different strains, is this important as there are a lot of variants of concern and new ones popping up?
Yeah, no, this virus, like the flu, mutates quickly and it changes. And the response, we're always afraid that it's going to mutate and not respond to all the immunity that we've developed. So they're going to tweak it to where it is geared toward the most relevant virus that's circulating now in the population.
Mhm. Now, moving on to COVID infection and a little bit of long COVID, maybe, there was a really great Norwegian study published in the New England Journal of Medicine recently, going into memory function and COVID even a long time after positivity. Can you tell us about that study and what they found?
Well, yes, and it's a great study done in Norway. It happened to be an ongoing study in 111,000 or so people. So they've been tested with this, what they call a validated questionnaire. So it's known to be linked to, neurologic outcomes. And in the 57,000 people who got COVID out of that 111,000, they found that there was significant but mild memory loss in many of the people. And they followed these people out to 36 months. It's an ongoing study. They have the data before people got COVID, after they got COVID. It is, if people that have had COVID say, I'm a little foggy, my memory's not as good, probably true, and it's probably related to COVID. Just another reason why you don't want to get COVID. They also found that the other factors that were associated with memory loss, memory disturbance, was their body mass index, which is, are you overweight or not? That was associated with it. And the other thing that was associated with it was the number of days that you were actually bedridden. So if you were really sick, and even though you didn't end up in the hospital, the number of days you were just like laid out flat in bed was also associated with this memory loss. So the more severe disease is associated with worse memory problems. But a very interesting study.
Very, very interesting. And to have such a large data set over such a large period of time, it'll be interesting to see if any more findings come out of that.
Yeah, no, it really will. And we're going to see more and more of these studies now that everybody's looking so closely, and that the NIH is just pouring quite a bit of resources into studying long COVID.
Mhm. And speaking of ways to hopefully prevent long COVID, longer duration of molnupiravir, which is a COVID antiviral drug, may be needed for at-risk outpatients. Can you please tell us about these findings?
Yeah, this is just another finding. Now, molnupiravir is the other approved drug to treat COVID. So Paxlovid is the one, and molnupiravir is the other. So the Paxlovid appeared to have more significant results. And I think it's probably the number one choice of the people that get treated at all, because a lot of people don't even take treatment, even though both of them are effective. But molnupiravir has some other advantages. It's just one drug. It doesn't have that booster built into it, and it doesn't have all the drug-drug interactions of Paxlovid. Okay. In a study that was done in non-hospitalized COVID patients, of over 500 people were studied. They found in these samples that if you took molnupiravir compared to nothing, all right, that the amount of virus in your body that they're measuring from a nasal swab dropped faster in the treatment group. Well, this makes sense. It's an antiviral drug, and the virus is supposed to go down. Your own body will bring it down, but you throw the drug in there and it goes down faster. I mean, the concept really is pretty simple. Less virus is better for you than more virus. However, they found that at the end of 5 days, remember the treatment is 5 days, only 14% had the virus level go down to where they couldn't detect it anymore. So that's pretty low. And then they found, interestingly, because they continue to follow these patients, it's a research study, at day 14, the molnupiravir patients, the virus load was higher than the viral load patients and people that didn't take anything. Now that's really strange. And what a virologist looking at this would say, you probably didn't treat these people for a long enough time. And the 5-day treatment course was based on very limited data, and that's what we do with the flu, with Tamiflu. And the original studies were so dramatic in terms of limiting hospitalization and death that they thought, oh, this whole thing, the body comes in and helps decrease the virus load no matter what you do, but these drugs make it go faster. So if the drugs are going to make it go faster, we've got to give the drugs for a long enough period to get that viral load down. Now that we have all these antigen tests, the things you buy over the counter and stuff, it's really surprising to me that more people are not utilizing those tests as some kind of marker for, going back to work, stopping the medication. Maybe people, if they had that test, I'm just hypothesizing here, that maybe if you use that test, and if it was negative on day 5, you could stop at day 5, but if it was positive, you would continue another 5 days, something like that. Just look at a longer treatment period in some people, maybe customize it so people don't have to take the drug every day. But I mean, it looks like, I think one of the issues with the drugs is that they're not prescribed for a long enough period of time. I don't think people are going to take this for a long time, no matter what. I mean, I think most likely it's going to be somewhere 5, 7, or 10 days in most people. Now, people that are immunocompromised, they may have to take it even longer. And we know people can rebound. And, maybe if they rebound, they need to take another course for a longer period of time. Who knows? I mean, these are all questions that we really have to look at and to examine scientifically, because we don't know at this particular point, but we're learning through studies like this.
Absolutely. And we'll keep our eye out for more studies going into these antiviral drugs just to keep up to date with that data. But moving into our non-COVID topics for this week, the country of Brazil, we've been talking about a lot in terms of dengue and outbreaks. Can you break down again what dengue fever really is and then what the struggle has been like in Brazil?
Dengue is another viral disease spread by mosquitoes, and it goes in these kind of 4-year cycles. It doesn't go away in between the 4-year cycle, but there's peaks and then there's valleys and whatever. About 20-25% of people get sick with dengue, and about 5% of them get very sick, and people can die from dengue. It can be a very serious disease. We're starting to see it in the United States. There were cases in Florida. There was a case in California. And this is going to increase because of the changing weather patterns and the change in temperature, and the mosquito that transmits it is spreading north for the United States. Brazil is kind of right in the middle of the whole thing. In 2023, they had 1.6 million cases reported. So in 2024, which is we're just starting the 3rd month, they've already had 1 million already. And so it's just a crisis over there. It's an emergency. There is a vaccine that's available, and there's another one that's being developed that's probably better, but that won't be out until the end of this calendar year. So for the next big season, and that's at least a year away or so. And right now, the vaccine that they have available, they only have, I think, a little bit over 3 million doses. So this is, Brazil has 220 million people. And so, they'll be more prepared for the next kind of round of this. But right now, it's really a crisis in Brazil. If you're thinking of going to South America, even the Caribbean, you got to keep it in mind that dengue is out there. And I've had one patient in particular I've been following for a while get very, very sick with a case of dengue coming back from the Caribbean. And you just have to be careful. The only thing you can do at this particular point, since there's no vaccine really available, is to try to avoid mosquitoes as much as possible.
Yeah, which is obviously a difficult task. If you are traveling anywhere, please make sure to check out the resources that are available to you. There are, travel warnings and health warnings, just advice that you can look up from our government agencies that are very generous with that data. But moving on, there was recently a study following the city of San Francisco and the use of antibiotics to treat syphilis and chlamydia cases. As we've talked about previously on the series, STIs have been booming in the US. So can you tell us about these findings?
Well, it's all about prevention and the doses that you use for whatever. So there's a thing called PrEP, stands for pre-exposure prophylaxis. And they do it for HIV, and it's very effective. If you take typically the HIV, most of the HIV regimens have 3 drugs or 2 super powerful ones. If you take 2 of just the usual ones, and you take it before you have HIV, if you're taking it, it's virtually 99.9% effective. Not 100%, whatever. Nothing's 100% in medicine. So anyhow, so those people taking it for to prevent HIV, they're getting all sorts of other sexually transmitted diseases. They're not getting HIV, but they're getting syphilis and chlamydia and gonorrhea and these other diseases. So there's a tetracycline antibiotic that's been out there for many, many, many years. It's called doxycycline, and they are giving 1 dose of that within 72 hours of sexual exposure at high risk. And they found it cut the rate of the bacterial infection, syphilis and chlamydia to be specific, by around 50%. That's quite dramatic because these diseases have been creeping up over the last few years. Syphilis was almost eradicated in the United States in the 1950s. And in 2022 alone, there were 200,000 cases. That's so many cases that they had drug shortages of penicillin. It's an intramuscular penicillin that you give, drug shortages of that because it's not very many companies make it. And I mean, that's the crisis with syphilis. And chlamydia is, there's at least 1.7 million people per year that get chlamydia. So anyway, in this report, that when they put this doxyprep treatment recommendation in, they had a huge, first of all, very few HIV cases, and then with the doxycycline part, they started to see a big drop in the number of cases. The people that didn't do that had, of course, a continued increase like they're seeing everywhere else. So, I mean, it's just another way to fight the battle against sexually transmitted infections. There's some controversy over, are we going to get the resistance to the doxycycline? There was studies with a relative of doxycycline, minocycline, in the 1970s, and it failed because they got resistance. So, you always have to play that game. Is this going to help or hurt in the long run? But we'll certainly see. People need to really be careful out there in high-risk situations.
Absolutely. And it'll be interesting to see if this strategy plays out on a more public level. Obviously, the city of San Francisco is very massive. It's a lot of data. However, we got to see how it works for everyone.
Very good health department.
Absolutely. Now, finally, our last story today is an update on the US measles cases. We've been talking about this the past few weeks. Can you give us an update on those numbers?
Well, the numbers keep going up. In the US, we now have 41 cases reported in, I think, 16 states. So that's high for just basically 2 months of data. In 2023 alone, the whole year, we had 58. So we're like way ahead of where we were supposed to be. And the state with the highest number is Florida, with 14 cases. 34% of all the cases in the United States are in Florida. And Florida is trying an experiment that is very high risk, in that they're allowing kids to go back to school that may have measles, and letting the parents decide when they can go back. They're not treating it like a serious disease. Is measles a serious disease? It is. You can also die from measles. It's not very many people die from it, but it is potentially lethal, and they can get measles encephalitis and die from it. So, and people get very sick. So there's now the health departments are like training emergency departments and outpatient clinics to tell them what measles looks like, so they can identify the patients quickly, because it's highly, highly contagious. It's as contagious as COVID. And so, it used to be the most contagious disease. Now COVID's more contagious. But these numbers are not big, but this is where you can stop an outbreak, when the numbers are in the double digits. If you wait till it gets up in the tens of thousands, this is really going to be very difficult. Now, the measles vaccine has been around for a long time, many, many, many decades, and safely used around the world. And the only people that are getting measles are people that are not vaccinated. So you can avoid this problem and this potentially serious infection if you get vaccinated, and after the 2 doses of the measles vaccine, 99% protection for the rest of your life. Even with 1 shot, it's like 97% or something like that. It's very, very, the vaccine works. It's old. It's been around forever, and nobody really very few people have any kind of significant reaction to that vaccine. Most people have taken it. It was almost eradicated, but now it's back because people are not taking all the vaccines like are recommended.
Yes, and important to note that it is typically recommended for children over the age of 1. However, if you are traveling with your child under 1 to an area where measles is endemic, there is possibility of approval for an early vaccine dose from travel clinics. So that is something to consider if you are traveling with a very young child.
Yeah, that's a very good point. It depends where you're going, and how much measles they have where they're going. But this problem is not unique alone to the United States. In the low and middle income countries, the vaccine coverage is much lower just in general. But even in the high income countries, some people are not getting vaccinated, just like they're not getting vaccinated here. And it's a totally preventable, but disease that can be very serious and fatal in some cases.
Mhm. Well, on that note, unfortunately, not a very happy one, but thank you very much, Dr. Murphy, for your time, your expertise, answering our questions, and breaking down this research all the way from Mali.
Okay, we'll see you
Well,
next week.
yes, and everyone have a very great weekend. Thank you for joining us. If you have any questions, please send them to our email or any social media that is linked in our description. Goodbye. Have a great weekend.
Have a great weekend.